Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with bilateral, really dry and flaky earwax and dead skin. We're just commencing with their left ear, and they suffer from a condition called superficial otitis externa. Otitis externa is an umbrella term given to an infection or inflammation or eczema or even psoriasis of the outer ear. And the outer ear consists of the satellite dish, what we call the pinna, so the cartilage on either side of our ears, the ear canal itself, and the outermost membrane of the eardrum, which is actually a very thin layer of skin, the same skin that lines the inner 2/3 of the ear canal. So that forms the outer ear. So if you've got any abnormality, infection or inflammation of those regions of the ear, we call that otitis. So otitis is Latin for infection of the ear, and externa, of course, is the location of this infection. So externa, so the external ear, the outer ear. So I'm just performing microsuction here, and as you can see, I'm just trying to wriggle and jiggle this really dry wax keratin plug out of the ear. Looks a bit like an insect, doesn't it, on reflection? So I can see the eardrum in the distance, but this dead skin extends all the way deep into the ear. And you can see the technique I used to insert the suction probe there. The reason why I'm just talking a bit about technique is we do have a lot of specialists that watch my YouTube channel, a lot of delegates I've trained myself, and once in a while I just like to recap and refresh on the technique, especially if you're right-handed and you're performing a procedure in the left ear like I am here, and the ear is very narrow and bendy. Quite often what I'm seeing at the moment is a lot of specialists are trying to enter the ear, especially if the wax is more lateral near the entrance, it's not a problem and the ear canal is wide enough. You are able to lead with the instrument and follow in behind with the endoscope. But when you've got wax deep like this, you can't lead with the instrument. You have to use the endoscope to stretch the ear open. I'm just going in with the endoscope here, and I'm just pushing the cartilage to the right to stretch the ear. And then momentarily, I, with my naked eye, look inside the patient's ear canal and insert with the tip of the endoscope. And once I've located the endoscope, so the endoscope has to remain really still and steady, so I have to lock my left hand, which is holding the endoscope. I insert the instrument over the top of the tip of the endoscope, and that ensures I'm able to insert the instrument safely into the ear canal without touching any of the sides. Now, with that technique, another benefit is especially in the case of the left ear, if you insert the instrument endoscope in that manner, your hands don't overlap, your left and right hand, so it doesn't restrict movement of the instrument. And quite often I'm seeing when you insert the instrument first, followed by the endoscope, especially if you're moving very deep wax, when you're trying to navigate around the bend and twist of the ear canal, the endoscope's getting trapped and it's almost touching the front part of the ear canal, so to the left, and then the specialist has to just go in further with the instrument, and the hands overlap and becomes a bit wobbly, and they lose control of the instrument. So it's just to remind the specialist of the 4 and 7 o'clock technique, so that'll refresh your memories, I'm sure. So just going back to the procedure, you can see I'm now just mopping up some dry skin, crusted skin on the base of the ear canal. I've got to be careful. It's like that game of operation. We don't want to make contact with the bony part of the ear canal, which is where we are now, because it would be, or if we do make contact, it has to be the most minimal contact, because that region of the ear canal, the inner 2/3, is extremely sensitive. The best analogy I can give is if you've got a toothache and you've got a nerve that's exposed and you have something cold, so an ice cream, for example, and it's extremely painful. I'm just thinking about it right now and reminiscing of how painful it is, but it's a very sharp, acute pain, and that's also the case when you touch the bony part of the ear canal and you make kind of really sturdy contact with it. So I'm just trying to peel away as much of this dry crusted skin off the ear canal. Now when we're on the cartilaginous portion, which is just about the border here, we can apply a bit more pressure, because cartilage is, as you can imagine, it's not rigid like the bone, so it has got some flex. The skin's a lot thicker, so it provides a buffer layer. There is some insulating fat and muscle as well. So we're really happy with that. I'm just going to proceed with this. They write it, and similarly, they've got superficial otitis externa. So the reason why we call it superficial is with this patient, they've got just kind of dry skin flakes of the ear canal. You can get more severe types of otitis externa. So, for example, acute otitis externa or deep otitis externa. That's when you also have swelling of the ear canal. So not only do you have dry skin, but you have swelling. You can also have discharge, what we call otorrhea. And then you've got, believe it or not, life-threatening otitis externa. So we call that necrotizing or malignant otitis externa. And that's when the ear canal is infected, but also the surrounding bone, the temporal bone. And of course, the infection can then spread from the bone that encases the ear canal to the mastoid bone, which is the bone behind your ear. You can actually feel that if you place your finger behind the cartilage on the outside, so the satellite dish, you can feel a bone behind there. That's what we call the mastoid bone. It's an air-filled honeycomb structure. And the infection can then spread towards the brain, towards the skull. Necrotizing, or as I said, the other term given to it is malignant otitis externa. It's more common in elderly patients or patients who are diabetic, so you have reduced blood flow to the peripheral parts of the body, so legs, eyes, ears. So when you've got an infection, it's vitally important that you have good blood flow, so the infected region receives all the white blood cells to fight the infection. It's full of oxygen and nutrients, which is all vital in the fight of killing an infection. So patients with diabetes have reduced blood flow because of narrowing of the arteries, and patients who are immunocompressed, so they have a weakened immune system, again they can't fight the infection as well, and that's why elderly patients are more prone to developing malignant or necrotizing otitis externa, because as we age, our immune system does weaken. Another hallmark of malignant and or necrotizing otitis externa is severe pain at night. And I was asking my colleague, an ENT surgeon, Mr Darius Rajali, asked, why is it at night? And they said, most ear infections, when you sleep, I know glue ear can also cause really severe pain at night. I've had that before myself, but most ear infections, if they're not severe, once you're asleep, you kind of switch off from it momentarily until you're more awake and you're more aware of it. But when you've got the pain that derives from malignant or necrotizing otitis externa, it's that painful that it keeps you awake at night. So it doesn't mean that if you've got an earache and it keeps you awake at night, you have this condition, but it is one of the hallmarks. Quite often patients with glue ear, so fluid behind the eardrum, they also suffer from pain at night. And that's because there's a tube behind the eardrum that connects to the back of the nose, the eustachian tube, and that's a drainage tube and a pressure equalizing tube. And that's more prone to getting inflamed and blocked at night because the blood vessels at the back of the nose dilate around the eustachian tube, so it creates more of a blockage, and therefore it limits the drainage of any fluids. And it does sometimes keep me, I once every 2 years or so suffer from glue ear. I had one at the beginning of this year. I did put some photos up on my Facebook page. You could actually see how inflamed my ear canal was. So with this patient, they are being prescribed some acetic acid, which can help with dry skin like this. And I've also recommended they use some medical grade olive oil spray. There's a link in the description if you want to purchase it. We only ship to the UK. I hope you enjoyed that video, guys. Take care. Speak soon. Bye.